they might have morning stiffness lasting less than 30 minutes. What can help them? Not doing anything. So if they take rest, it can feel better. Heat, any kind of analgesics which can help them to feel better. Presentation, as I said, they will have loss of active range of movement, internal rotation, external rotation, and elevation. Shrug sign can be positive. Crepitus can be positive. We have British Elbow and Shoulder Society pathway for imaging, and that's what we follow in UK for most of the shoulder patients. And what we do is that usually you do an X-ray to AP in the scapular plane and axillary view. The reason why we do it is that because we want to differentiate diagnosis to make sure there is nothing else is going on, and to rule out if there is any frozen shoulder. So for example, if I send a gentleman for X-ray, if the X-ray is clear, and if he has got a limitation of movement, I might be thinking more on the shoulder, frozen shoulder, or any secondary rotator cuff related stiffness problem rather than osteoarthritis. So what's the management? Management is different from frozen shoulder. So even though the joint is stiff, there is no need to force or stretch, because as we know, the joint is already obliterated, so that can increase their pain. Gentle distractions, mobilization are fine to do. Exercise usually will take 6 months to show any improvement. So just tell them to be little patient, resilient. You can start anything like isometric exercises in any position. Anterior deltoid rehab program. I'm not sure if you're aware of, but in UK we have Torby program, which means that you use the deltoid rather than using a rotator cuff. So irrigating the joint less, and hopefully that will help to improve the range of movement. Hyaluronic acid has been useful, but again, we don't have research to back that up. We do inject corticosteroid injections for acute exacerbation, but that's mainly for pain. So when do I send this patient to an orthopedic consultant? When he feels, or the patient feels, that it's affecting their activity of daily life, sleep is a problem, and function is limited. So they get an opportunity to an orthopedic surgeon. In UK, we cannot send the patient to a surgeon until they satisfy the criteria of having a rehabilitation for 6 months, trying analgesics, and symptoms not getting better, and range of movement getting progressive limited. As I said, injection therapy, something we do for the shoulder. There is no evidence for injection therapy at the moment, but that's mainly for the pain relief. There are studies which have mentioned there's a short-term effect. It's very useful for diagnostics. So sometimes if you're not sure what's causing the pain, and if X-ray comes out as an osteoarthritis, it can be quite useful to inject and see if that helps their pain. And if they want to go and see a surgeon after that, that's a quite good diagnostic aid. As I said, hyaluronic acid, more research is needed. At the moment, we cannot provide in the National Health Service. It's very much into the private practice. So next stiff shoulder is frozen shoulder. We all know it's called adhesive capsulitis, characterized by both pain and stiffness. Codman defined as a condition which comes slowly over the deltoid insertion, inability to sleep, painful incomplete elevation and external rotation, restriction of movement, being both active and passive, with a normal radiograph. And obviously it can be very tiring to a patient. Presentation is usually 35 to 65-year-old. In Japan, it's called 50-year-old shoulder. Insidious onset, usually in idiopathic. Sometimes it can happen with the trauma. So if they have any trauma, they can develop secondary stiffness. Nature of pain can be really severe pain, unremitting pain, affecting the sleep, and patient finds difficult in moving the shoulder, especially if they have any sudden movements that can irritate the capsule and give you pain. Location is again widespread around the upper arm and shoulders. Any movement will be painful, and in early stage, they may present like a symptom of impingement or subacromial pain syndrome. And as the time goes on, then only you can see the limitation of the movement. So it's very difficult at early stage to give them any kind of pain management. Obviously, we know the diabetic population is more affected. If the patient has got frozen shoulder in one shoulder, they are likely to get in the other shoulder sometime within the 5 years, at least that's what the data says. Non-dominant hand can also get affected, up to 50% risk for the contralateral shoulder within the few years' time. So if you have frozen shoulder, you're likely to have in a few years, but 2 to 5 years is a general guideline. Females are more affected than males, 3:1 ratio. So we know that there is a primary and secondary frozen shoulder. Secondary can be due to the systemic. So if you have a family history of diabetes or you yourself have a diabetes, hypo or hypothyroidism, cardiovascular diseases, any low-grade inflammation, and genetics like Dupuytren's fracture. So these are the systemic causes which will predispose you to have frozen shoulders. So if you see this in the history of a patient, you know by the history that they're likely to have that problem. Extrinsic factors could be trauma, cervical radiculopathy, cerebrovascular accidents, or TIA. Intrinsic factors could be local trauma, so trauma within the joint, shoulder surgery, rotator cuff injury, or infection within the joint. We all know pathophysiology. There's a thickening of the coracohumeral ligament, capsule thickens and the rotator interval shrinks, capsule thickening in the axillary recess, and synovial membrane thickening in the axillary recess and rotator interval. The bursa get distended, long head of the biceps get irritated and develop synovitis, and the whole area get angry, inflamed, or red. We have 3 stages. First one is freezing stage, usually lasts for 30 minutes, the whole stage cycle, but it can vary on individual. It can last from 6 months to 24 months. Freezing stage is usually pain is more predominant. So if you ask patients what bothers them, they will tell pain and then limitation of the movement. Frozen stage for me, but I can't reach, I can't comb my hair, I can't reach my back pocket. So movement is the main problem. Thawing stage symptoms are improving, so both pain and movement are getting better, but still it's not full. Examination, obviously we have to an extent mandatory in UK if you suspect frozen shoulder to make sure nothing else is going on. Active range of movement is equally good. First thing we do is check the external rotation, both the arms, and if you see one side limited, then obviously you're likely to have that sign. Shrug sign is again important. So basically what it means is that patient will not lift the arm. Instead of that, they will lift the whole shoulder blade because the whole capsule has got tightened. So they can't separate arm from their bodies. Instead of lifting the arm, they will lift the whole shoulder blade. So why we do X-ray? So the guidelines came 2 years ago and none of us were very happy because we were thinking that we are sending more patients for radiology. But the reason was there was a study done by Roberts et al. In 2018. He has seen 350 shoulder retrospectively in 42 months. And out of that, 342, which is 97.7%, had no pathology, which is fine, majority of them. 8 patients, which is 2.3, found positive features. Of them, 6 had severe osteoarthritis, and 2 had serious pathology like fracture and lucency, which means history of lung cancer. So if we don't do this, we're likely to miss some patients, and which we don't want. What is the management? So if a patient comes in a stage 1, we don't do much. I don't know what other part of the world, but in UK the guideline is neglect, which means you supervise the patient, tell them what to do, but don't do active intervention. So advice and education, reassuring them, telling what the problem is, and educating them to do some kind of exercises like swimming, active home exercise program, gentle stretching, and things like that. If that doesn't get better, then obviously we do more invasive interventions, but otherwise it's very much gentle exercises. Very rarely I do manual therapy, and exercise therapy, there is some evidence that group classes are better, but we don't know that's because of psychological benefit or is it because of actual exercise benefit. Corticosteroid injections have been useful. In UK, we do hydrodilatation, so we have a radiologist who do that for us. And if that doesn't get better, then obviously we send it to the orthopedic consultant for consideration of arthroscopic capsular release or manipulation under anesthesia. We are moving away from manipulation under anesthesia because that has got more side effects, and hydrodilatation and ACR is sufficient to give them the benefit they need. With regards to physiotherapy interventions, manual therapy has some kind of benefit. As I said, group classes are better than one-to-one. What we don't know is that which kind of manual therapy is helpful. We know posterior directed mobilization is better than anterior in increasing the external rotation, but this is just the one study has published with a limited number of patients. If you feel that you have time and if you would like to do, then obviously it's a good intervention to do it. High grade mobilization is better than the low grade. So again, if you're a manual therapist person and if you have time to dedicate to the patient's frozen shoulder, you can try that and see what intervention, see the intervention's outcome. Stretching exercises have shown beneficial, and what they have found is that external rotation extension combined with adduction produce the most strain of the coracohumeral ligament. So if you're thinking of stretching that ligament, increasing the external rotation, then this is the best exercise to give them to do at home, and you can do them in the clinic as well. Eccentric exercises we have just started to use. What they do is it increases sarcomere over a 12-week period of time. No evidence to show it increases the range of motion in the frozen shoulder, but some people find it useful and they do it in a clinical setting. Stretches are usually beneficial. PNF techniques are also there, but I don't use it. Isometric exercises have been shown beneficial, not only for frozen shoulder, for any kind of atypical joint. So if a patient comes to a clinic and if they're in a lot of pain and if they can't do anything, tell them they are like analgesics, they are like painkillers, and all they have to do is they just make a strong fist, so that will contract their rotator cuff muscles. They can move their arms strongly against any resistance. It could be their own other hand, or it could be any kind of a barrier, which is like a wall or door, or something like that. If you hold for 30 to 60 seconds, apparently you get better benefit, and they can hold as hard as they can. So you have to instruct them to hold maximum resistance. So push them as hard as you can, hold for 30 to 60 seconds, and then relax and repeat. And obviously females have more response than the males in this study. I don't know the reason. The latest Cochrane review tells that the manual therapy and exercise therapy is not as effective as corticosteroid injection. So if the patient doesn't get better, then obviously don't waste time. If they feel that the pain is getting worse, range of movement is limited, then obviously refer them to the orthopedic opinion. When I refer to the patient, when I feel that their external rotation is not increased or is not increased from the past to neutral in 3 to 6 months' time, if they have a history of diabetes mellitus, then I know that their improvement is going to be slow. If they're struggling to do their job, activities of daily living, and if they have night pain, sleep is affected, then obviously that's again another reason to refer. And as I said, we refer them for the hydrodilatation and near ACR. Now there are 2 studies happened, and the result might be published sometime soon, either this year or next year. One of them is the United Kingdom frozen shoulder trial. So what they have done is that they have recruited 500 patients from all over the UK, divided them into ACR, which is arthroscopic capsular release, manipulation or anesthesia, and physiotherapy. So 2:2:1 ratio, which means every 2 patients goes to arthroscopic capsular release, 2 patients will go to manipulation or anesthesia, and 1 patient will go for physiotherapy. And they are going to the outcome measures will be more looking into cost effective as well as patient reported outcome measures. So this will help to develop a guideline in UK, and I think result might be out sometime next year. There's another interesting study which was done by Louise Coleman. You can see the bottom one. It was done in Australia. She is one of the students of the Karen Ginn. Those of you know, Karen Ginn is one of the leading musculoskeletal researchers in Australia. So what she has found in her study is that there is an element of muscle guarding. So what our understanding of frozen shoulder was that it is a frozen shoulder, which means there is an actual thickening of the ligaments and capsule lining. This study has proved that there is an element of muscle guarding. So she has recruited few patients, I think it was 6 patients, and in theater under anesthetic, she could able to move and get the full range of movement. So no manipulation was required and patient could achieve full elevation, full external rotation. So the study had to be stopped because ethics was not approved for this. Ethics was approved for the frozen shoulder, but that will be interesting to see what they do later on. Now coming to the other cause of the stiff shoulder, which is AC joint osteoarthritis. It's called unstable shoulder. We have 3 types. So traumatic, atraumatic, and muscle patterning. So traumatic, we all know there has to be a history of trauma. Somebody has fallen on the shoulder playing in the rugby or football, and usually they require surgery more than the physiotherapy. Physiotherapy you can have as a prehab, which means while they are awaiting for the surgery, you can start their rehab and build their muscle strength, but most likely they will need surgery to make their shoulder stable. Atraumatic, which means they never had any trauma but still has a subluxating or dislocating shoulder. Most of the time they need rehab. If they don't improve, then they might end up having surgery. Last one is muscle fattening. What it means is that some of the muscles are tight, some of the muscles are weak. In front, most likely it's going to be the pec major, which can be tight, and at the posteriorly, it's more latissimus dorsi. So sometimes they can create an abnormal force with the rotator cuff. So the shoulder can mimic or sublux forward if they have got pectoralis major or minor too tight or too short, or if they have got really tight latissimus dorsi. We don't know whether this is the cause and effect or this is something they develop over the period of time. So what we don't know is that whether the muscle gets tight over a period of time because the rotator cuff is weak, or is it something they're born with it. Okay. And most of the time, muscle patterning patients, either they will have hypermobility or some other kind of connective tissue disorders. And what we want to know is that which direction their shoulder was dislocated. And obviously we have anterior 85%, posterior 10%, and multidirectional 5%. So this is the Stanmore triangle. This is what we follow at the moment in UK. So Stanmore is a Royal National Orthopaedic Hospital in London, and they specialize in rehabilitation of these patients. So as you can see on the triangle, top is a traumatic, which is again happening due to the trauma. Second one is atraumatic structure. What it means is that patient did not have trauma, but still you can find a structural deficiency or structural pathology in their shoulder. And the last one is muscle patterning. As you can see, the patient is quite bendy. Most likely they will have rehabilitation. They would have never had any trauma or might have some subluxation, but usually it's because of the muscle patterning. So traumatic type 1 or anterior torn. So usually bone will be involved and there can be bony bankard. What it means is that the labrum might be torn, the glenoid labrum. Hill sacks, which means they might be dents and the shoulder has come forward at the humeral head. There could be labral tears. So slap is superior labral anterior posterior tear. So top of the biceps can peel off, and that is called as a slap lesion. And obviously we have a bankard, which is the front of the glenoid labrum, which is torn due to the injury. Capsular and ligament injury is very common. Cuff tear can happen. Usually somebody is over 40, and axillary nerve can get damaged as well. So what we do to these patients, usually called TUBs. So they are often traumatic, unilateral, bony bankard, and they end up having surgery. The common procedure is lateral J, 90% of the coracoid reabsorption, and other procedure is conjoint tendon, the big stabilizer, so they split the subscapularis tendon. Traumatic type, sometimes you can get posterior instability. It's very rare. It can happen due to seizures or electrocutions. So somebody get electrical shock, or if they have fits, their shoulder can dislocate posteriorly. It can also occur due to trauma or sports. Same structural issues can happen, which happens in anterior injury, and that is because it's the back of the shoulder. There'll be reverse bony Bankart, reverse heel sacs, reverse Bankarts in the lateral chairs, and capsular ligamentous injury. Do all need surgery? Not really. So recurrent rate is quite high for the anterior and traumatic ones. Up to 95% people less than 24-year-old will get this dislocation, and they take a lot of physical activity. So what happens is that even if you operate them, they're likely to be highly active, and chances that they're going to have this injury again. Only 48% of the people return to previous level of sports activity. So what the pathway is coming now is to try as much as possible rehab, rehabilitation, and if they don't improve, then send it for surgical intervention. Do all these patients need immobilization? Probably yes, for comfort only. We are moving away from long period of immobilization, and usually these patients will need a week of mobilizations. The more they take out the sling and they move their arm, the better it is to reduce the stiffness, weakness in the rotator cuff muscles. And isometric exercises can be started from the day zero alongside the mobility, gentle mobility exercises. It could be closed chain, which means moving your arm with the support of something in forward and circular direction, but we want them to move as soon as possible. Atraumatic structure, which is type 2, it means somebody is loose, they never had any trauma, but their capsule is loose, their ligament is loose, they're subluxating most of the time. These people can be party trickers as well, which means teenagers just showing off their friends, taking subluxing the shoulder out and putting back in. They usually have hypermobility, which means increased mobility in their joints. Sometimes there might be congenital defects. They might have some micro trauma. Usually they are quite active in the sports occupations. If they're using that arm more often, they're likely to have this instability more. And if they're using this aerial activities arm more, they can sublux while doing their aerial activities, which is like dressing, brushing, and things like that. So we have atraumatic type 3, which is muscle fattening. Most of the time it is psychosocial issues because it's been there for a long time, so they have developed the central sensitization, central nervous system adaptation. A congenital structural variations may be there. They may have glenoid dysplasia or any other kind of torsion or eversions of the glenoid. Humeral head morphology might be different. They might have increased laxity in the ligament. And again, genetic cause could be there, which means they have hypermobility syndrome, connective tissue disorders like EDS, Ehlers-Danlos syndrome. So usually mnemonics are ambry, which means they are atraumatic, multidirectional, bilateral rehabilitation, and if that doesn't get better, then obviously inferior capsular shift, but that's very, very rare cases. So how do we treat them? What we do is that we find out there's a Brighton criteria. So there's a major and minor criteria, and we have to score each joint. And if they score more than 4, and if they have joint pain for more than 3 months in 4 joints, then they are diagnosed as a hypermobile, and then we can look into specific joints and see what is causing the pain. I'm sure you might be aware of this. So how we score them in the Brighton hypermobility score is that if they can bend their wrist and touch their thumb to the same forearm, they score 1 for one hand, and if they can do it with 2 hands, they score 2. Same time, if they can move their little finger beyond 90 degrees for one hand, they score 1, and for both the hands, if they can do, they score 2. If they extend their elbows and it goes into hyperextension more than 10 degrees, then they get scored for each elbow. And if they stand in the weight bearing position and knees goes into hyperextension, they get score for each joint. And if they stand unable to reach to the floor with their hands, then again they score 1 for that. So its score is total out of 9, and it's quite accurate for diagnosing the hypermobility. And if they have that, that may be the cause of their shoulder subluxation or dislocation or instability. So as I said, history is very important. If it's traumatic, you want to know the direction of dislocation, how they relocated, how long it was immobilized, how many previous episodes they have, how many they have in a day, and how often, if it happens, or in a week or in a month. So you want to know the entire episode and the diary log of it, any past medical history, hypermobility, depression, anxiety. Same thing if you come for the atraumatic, you want to know whether they can feel the shoulder, whether it's in the joint or not. So sensation is very important, because sometimes they have a proprioceptive deficit due to the injury of the microtrauma of the ligament, and they can't feel where the shoulder is. Again, asking them when it happens, how often it happens, spontaneous relocations, any previous episodes, how many and how often happens in a day, week, or a month, any past medical history, hypermobility, depression, and anxiety. Obviously, this was the Hedges. We talked about the anterior instability test. So if you go from the anterior to superior, you can do the apprehension test and relocation test, and that's quite specific. So apprehension test is if somebody you're suspecting of anterior traumatic dislocation or anterior dislocation, all you want to do is that make them supine, passively take their arm into abduction and external rotation in 90 degrees, and look at the patient's face. If he feels apprehensive, scared of pain, then obviously that's positive. So it's not the pain, it's the apprehension on their face will make them positive, and that's 95% specific. Relocation test is exactly opposite. So from that apprehension maneuver, you apply an AP force to the glenohumeral joint, and if their face gets relaxed, then obviously you know that they are feeling safe and secure, and it's 90% specific. Bony apprehension, again, it's for anterior inferior capsule. You're looking into passive external rotation in 30 degrees of the arm in caption, and apply a posterior anterior force to the humeral head. If the patient is apprehensive, then obviously you know there is an injury to the bone, and it's usually done after the immediate trauma. So if you get a patient in ER, or if they come to you say that they had an injury today or yesterday, that's more specific. Hyperabduction or Gagey test. So you make the patient sit on a table or chair, and you hold their shoulder with the one forearm, you stabilize that, and then lift the bent elbow at 90 degrees and beyond. If it goes beyond 90 degrees, positive Gagey sign. Pain and click is positive, and compare the movement to the other side. If both the sides are beyond 90 degrees, which is more than 10 to 20 degrees from 90 degrees, then usually they're likely to be hypermobile. We don't consider it as a positive. It's usually one arm has to be more than the other. Specificity is quite okay, it's 85%. Posterior instability test, we do posterior apprehension. So again, patient 90 degree flexion, 10 degree of horizontal adduction, and AP load through the elbow. Patient is in the supine position, and you check for patient's apprehension. Very specific, 99%. You don't need any other investigation if you feel that. And the pain should be at the posterior aspect of the shoulder, and patient should feel that the shoulder is about to come out. Posterior jerk test, arm in the horizontal abduction, apply axial load, take into the horizontal adduction, and apply a strong jerk in the abduction external rotation. If you get clunk or pain, then it is positive. So all you have to do is that make the patient sit, hold the elbow in 90 degree shoulder abduction, and quickly grind the labrum or the glenoid and see if you get any kind of clunk or pain. And obviously this is your bony apprehension test, which we discussed that. And this is apprehension test for anterior instability done in the supine position, and the relocation test. This is a test for the posterior instability, posterior apprehension test. So you're just making sure that you apply the axial load to the elbow, and the patient should feel the pain where your arm is at the posterior aspect of the shoulder, and if they feel apprehensive. King's test or jerk test is that you can make the patient sit nice and relaxed, take the arm into abduction and external rotation elbow, and then put a force like grinding the labrum or compression and rotate the arm into internal to external rotation. Inferior instability, we talked about gauge test, and this is how the arm should be in hyperabduction position. I don't do circus test because I don't find that useful, and there are too many false positives. So what are the rehab principles? The rehab principles are really keeping it simple: restore the range of movement, improve the cuff function, improve the speed of activation of the rotator cuff, improve the proprioception, because these are the patients who might be deficient in the proprioception, improve the isometric resistance to the external rotation forces, and improve the kinetic chain trunk stability. So it's not just about the shoulder, making sure that you make the person strong and make them understand that the whole kinetic chain needs to work rather than the shoulder. So there are 3 rehabilitation specific programs for instability. One is Burkhead and Rockwood. Then we have Darby shoulder instability program and the Watson method. I usually do more of Darby shoulder instability, and I'll tell you why. So this is the Burkhead and Rockwood program. So what they do is that strengthen the rotator cuff and deltoid using the resistance band, and those with the atraumatic instability gain good or excellent results. So basically you take the rotator band and move into external rotation, internal rotation, abduction, and extension. Darby shoulder program, I have given you the YouTube link, so you've got all the exercises in that, and this is very specific. You said because section 1 and section 2, it takes the patient from very low level and then challenges to a very high level. So if you feel your patient is ready to return to sports or doing any high demand activities, you can challenge them all the way through the program to section 2. If you feel that you just need to rehab them, then obviously you can do it in the section 1. And what the exercises are, basically you drop and catch 1 kg weight in 90 degrees caption. Tell them aim for 100 reps. They don't have to, but if they can aim, that would be great. Progress doing with the eyes closed or standing on the one leg. So what you're doing is that you're challenging their proprioception, challenging their kinetic chain. Then obviously same exercise they can do in the abduction position and external rotation position. So that will strengthen their anterior rotator cuff muscles and posterior rotator cuff muscles. Same thing in the prone line, so they are more likely to work on the posterior cuff here, and again aim for the 100 reps if they can. Falling and press again the standing. So if there is a wall, asking the patient to fall on the wall and aim for 50 reps. If they can do, then obviously they can increase their reps. They can always alternate with the closed eyes or standing on the one leg. If they are safe on the wall, you can take them down slightly and falling on the plinth or a couch, and again they can aim for the as much as repetition they can. The 3 repetition if they can, that's great. And then obviously if they can do with the 2 hands, progress with 1 hand. And if they have progressed from the couch, you can always bring them safely on the floor. And it's a plyometric push-up with a hand clap, aim for 20 if they can, and if they can do it, then they can do it with 1 hand or closed eyes. So challenging their proprioception, strength, and conditioning. If you feel your patient is not safe for this, then obviously you can stop anytime. It's not for everyone. Then obviously progressing on from there, you can always fall against the door wall. So your hand should be in abduction, external rotation, and body should fall forward. I haven't done this for my patient yet, but I know a couple of my colleagues have done, and they have got good results, especially for the athletic population. When you come to section 2, it's more about proprioception, so taking the ball and moving up and down, forwards and sideways in circular motions, holding for 60 seconds, just making sure the shoulder gets good proprioception. Progressing it on the floor with the one hand, just moving forward, sideways, and see how much they can take the load and aim for 60 seconds. And if they can do as much as time they want. Kneeling on a ball and hand roll to take the weight through the ball, and then again moving forward, sideways, and increasing their proprioception, but same time challenging their cuff muscle as well. And this is more close kinetic change, so they're quite safe to do these exercises. Progression again is standing on the one hand and see if you can move forward, your body forward and sideways, and if you can hold that for 60 seconds. And if you can progress with that, then you can aim for push-ups as well in that position. Again, taking the ball, so proprioception challenging, but challenging the whole upper body strength, core, as well as lower limb stability as well. So making sure that the pelvis doesn't drop, shoulders are in line, and spine doesn't go for hyperextension. Elbows are slightly flexed, so not hyperextended, and the weight is directly, and the challenge is going to the rotator cuff. As they progresses, you can go for a double ball, and obviously you can change the direction of the balls. One can go forward and one can go in other direction. Aim for 60 seconds and improve it more. Next, the Watson method. The Watson method is starting the same exercise as TheraBand exercises, but starting from the supine and then going into standing position. Pretty much with the TheraBand, standing at the 90-degree abduction, external rotation, internal rotation, and progressing. Starting at the 0-degree abduction, external rotation, internal rotation, and progressing to 90-degree abduction, external rotation, as you can see in the photo. Then we have this paper published, and that is for the people who cannot do high level of exercises. This is very much facilitating them if they don't have any sensation, any sense of where their shoulder is. Then just giving them feedback and proprioception to the hands and telling them where the middle border of the scapula is, facilitating that, and encouraging that external rotation and some kind of dynamic movement of the cuff. So either it could be the elevation or assisted isometric exercises. Same thing they can do standing on the one leg, standing on the tiptoes, sitting on the gym ball. So what we want is that basically engaging the whole kinetic chain and activating the muscles. As they get better, they can progress it, and they can progress it again in the supine line, free arms. So you can see in the first photo, the arm is supported with the towel, and it's a free hand, so they can do internal and external rotation. And as they get better control, they can progress with the weight. So that's more working on the posterior cuff. If you come to the right hand side, you can see in the photo it's more working on the anterior cuff, which is subscapularis, and anterior superior aspect of the supraspinatus. So again, arm is supported with the towel. As they get better, they can use a small weight. It could be 0.5 kilogram, small water bottle, or tin of beans, anything which they can control easily. And as they get better, you can take off the support under their forearm, which means now they have got to hold their arm in 90-degree abduction and external rotation without any support against gravity. So the challenge is to maintain the shoulder in that position and then do the internal and external rotation, whatever they can. So they're working through the inner and outer range of the rotator cuff muscles and challenging the muscles to the direction. Now we are coming to the rotator cuff related shoulder problem, or subacromial pain syndrome, or impingement syndrome, depending on what you call. We usually call them weak and painful shoulder. It covers a range of pathologies. As I said before, rotator cuff tendinopathy, cuff tears, biceps tendinopathy, calcific deposit, or bursitis. So important thing to consider here is that look in the history. If there was a large cuff tear, if it is a traumatic injury, patient can't lift their arm, move the arm. If a sudden onset, night pain is present, weakness is there, then obviously refer the patient onward to the orthopedic consultant for an opinion on the surgery. but otherwise we manage all the chronic tears, we manage conservatively. So what is rotator cuff related shoulder pain? It's usually any shoulder pain which presents from age 35 to 75. Acute could be trauma, gradual could be degeneration. Nature of the pain could be sharp, catching, aching, dull. Location is usually upper arm, diffuse. Aggravating factors could be like any other shoulder pain, lifting, moving arm, reaching overhead, behind, sleeping or leaning on it. And it gets better with the rest and analgesics. What are the other key points? If they're young, less than 50, with a history of trauma, severe shoulder pain, as I said, and if you have positive lag, just refer to the orthopedic opinion. If there is a pseudoparalysis, which means it's not a cuff tear, there wasn't a trauma, they think it's because of the muscle weakness, muscle atrophy, or any kind of nerve injury, then obviously this is not a cuff tear and it doesn't need an urgent pathway. So lag tests are better, but still not perfect. External rotation lag is for specificity is 94%, drop arm test is 73%, and lift off is 84%. So none of them is 100%. So initially, we thought there is an impingement, and the reason why we thought because there was a classification of acromion by the Biglani. We all knew that type 1 was flat, type 2 was curved, and type 3 was hooked. And our understanding at that time was that the acromion, which is responsible, the type 2 or type 3, which is curved and hooked, might be causing some kind of impingement, irritation to the tendon, and that might be the cause of the pain. But as we are learning more and more, and what we are understanding, it's not usually the acromion to blame for. Because majority of the rotator cuff tears are found on the articular side, not the bursal side. So if you see the studies by Elman, 76% on articular side, sorry, Fakuda 82% articular side, and Payne 91% articular side. It is not possible to tell which patients have symptoms and which patients don't from the MRI alone. So we need the clinical test and the history as well. What also we know is that conservative management versus arthroscopic subacromial decompression. So before, as we are understanding was at that time and we all are learning, we used to think acromion is the culprit and we used to do decompression of the acromion. What we're learning now is that 71% of the post-arthroscopic subacromial decompression patients go on to have a rotator cuff tear, which means if there is no acromion, still they get the tear, and how that's happening. No difference between arthroscopic subacromial decompression and bursectomy, only good long-term follow-up. So if you do arthroscopic subacromial decompression, which means if you think there is an impingement because of the acromion and shave the acromion, and if you compare with something which you think the bursa is inflamed, and without shaving the acromion, just take off the bursa, in the long term, there was no difference in the outcome of those patients. Re-tear of the rotator cuff post-repair is also very high. We know that for 6 months, any rotator cuff repair is more likely to re-tear. But we also know that it doesn't affect the function. So no matter if the cuff tears again after repair, it doesn't affect the function and quality of life of the patient. And this was a national study, UCUF in the United Kingdom. And it was done by one of the leading surgeons. What we also know is that physiotherapy is as good as subacromial arthroscopic decompression in achieving the result for impingement. So this was a study published in 2017 by the Bird et al. So David Bird is one of the physiotherapists in UK, and he started a study called Can Subacromial Arthroscopy Work? And it's called Seesaw trial. It was kind of controversial trial in the United Kingdom, but as you can see with the findings, what they say is that there was no difference between the patients who have been randomized. This was one of the randomized control trials. Patients who were randomized to subacromial arthroscopic decompression, and then arthroscopy but no treatment, and then one arm did not have any treatment at all. So in a 1-year outcome, there was no difference in the patient who went under arthroscopic subacromial decompression, or who just has a diagnostic arthroscopy, or who did not have anything at all. So that tells us that there is more underlying mechanism to understand the shoulder pain. And since then, BMJ has published a guideline and it started educating patients. And what it says is that there was a Symptom trial, which was done, I think, in Sweden. So they randomized 139 patients to arthroscopic subacromial decompression and 63 to diagnostic arthroscopy. And there was no difference. Arthroscopic subacromial decompression provides no clinically relevant benefit over diagnostic arthroscopy. What we also know that patients are in pain and they are suffering, and we need to help them. So what we're trying to do them is that give them a reassurance, analgesics, and give them the information with regards to rehab. And it's more and more important now to educate the patient and make sure that they understand that there is no quick fix and they have to work towards it. So again, the summary of the trial is arthroscopic subacromial decompression plus non-operating management is as good as non-operating management. So this is not to say that there is no role for surgery, but majority of the patients will get better for the impingement with the exercise and education. Obviously, this was a result after 1 year, and they have taken the quality of life as well as pain scores like VAS scores and global perceived effect of their own problem. So what we understand with the rotator cuff related shoulder problem now is that we think it's a cuff which is weak and it doesn't control the humeral head or centralize the humeral head. It may be something like internal impingement, which happens in other tendons like patellar tendinopathy or patellar impingement, or in Achilles tendinopathy. What we know is that we need to do some investigation to rule out serious pathology, and hence the guidelines are to do an X-ray to rule out any kind of calcific deposit, cancer, or cuff tear. So if there's a cuff tear, there will be the high riding of the humeral on the X-ray. And obviously calcific deposit, we can see that. And if there's an illucency, we can suspect that there is any kind of sinister pathology, especially if the patient has a history of cancer in the past. What we also do is that ultrasound is quick and cheap. So in UK, we have got one-stop clinics, one-stop ultrasound clinic, and they are run by the extended scope practitioners or orthopedic consultants, sports physicians. They're quick and cheap. They check for the tears on the same day, can check for the calcific deposit and bursitis, but it's very much user dependent. So it depends on the person's knowledge and how much they have the understanding of ultrasound, because there could be a lot of artifacts. MRI is expensive in UK. There's a long wait, usually 3 months sometimes in the area, but it can check the quality of the muscles like fat atrophy or fraying, or the quality of the tendon. But this is not the first priority. It's considered in the non-responders in the United Kingdom. What we do to these patients, so what we know is that they have symptoms and we need to help them. So something called Jeremy Lewis has started symptom modification test. What it means is that we have to find out a way to relieve the patient's symptoms. We don't know what it is, so it's a trial and error and it's a hypothesis. So if the patient's pain gets better with the thoracic extension, then what we will do is that we will encourage the patient to do that kind of movement more in their rehabilitation or exercise program. Increasing the thoracic mobility, increasing the kinetic chain activation, but increasing thoracic extension along with the rotator cuff rehabilitation will be the way forward in my rehabilitation. If the patient's pain doesn't get better with the thoracic extension, but gets or improves or changes with a single leg stand, then obviously I'm going to start that as my strategy to improve the patient's engagement in reducing their symptoms. So if anything I can change their pain quickly, I'm going to tell them, okay, this is working, let's do that. If the same single leg doesn't work, I'll go for the contralateral leg. So allow the patient to stand on the opposite leg lift the arm up. What it means is that I'm engaging their glutes, I'm engaging their trunk extensors, and I'm engaging their rotator cuff muscles through the kinetic chain. And if that changes something in their body and helps to improve their symptom, that's enough for me to start that. This is not in cause and effect, this is trial and error. And if I can make that change and if the change continues, that's good for me to start. If thoracic extension and single leg stand doesn't help my symptoms, then I do scapular assistance test. And what I do is that I hold the scapula and try to move forward, change the scapula position. So I ask the patient to stand or sit and support the middle border of the scapula and help in elevation of the arm. What it tells me is that there might be some kind of weakness in the periscapular muscles, or there might be some kind of imbalance in the rotator cuff muscle, which is not helping the scapular movement to be facilitated quicker. So if that makes any difference in the patient's pain, I'm going to encourage that movement and I'll incorporate that movement in patient exercise. What we know is that that can activate the serratus anterior and trapezius muscles, and both are important for the forward movement and elevation. If thoracic extension, single leg stand, and scapular assistance test doesn't help my patient, then I do something called scapular resistance test. So I put the patient against some kind of weight. It could be wall, it could be floor, it could be any weight in their hands in supine lying, weight going to the ceiling, and see if they can do their movement. So if they tell, okay, when I do this movement, my pain is better, I'm going to incorporate that in their rehabilitation. What I'm thinking in my head is that there might be pectoralis minor tightness, or there might be weakness of the trapezius and serratus anterior muscles. So if I feel there's a tightness in the pec minor, I might do some stretching, but definitely I'm more looking to strengthen, focus on the scapular resistance test, getting the scapula more into challenging position with having it. If that doesn't get better, so if my patient tells that thoracic extension, single leg stand, scapular assistance doesn't help me, my symptoms are still there, then I give resistance against the external rotation. So I may ask the patient to push against my hand while elevating their arm, or push against their arm while staying at home against the wall or against the door, and see if that makes their pain better. And if that makes their pain better, then I might just tie a TheraBand or rubber band or resistance around their arm and ask them to do those exercises into elevation against the resistance. What I'm thinking in my head is that there might be some posterior cuff weakness, posterior swing activation is improving their symptom, and that's good for me to start. As I said, this is hypothesis, this is my way of doing it, so that's how I do the rotator cuff rehabilitation and get the result of the patients. If they don't improve, then obviously I modify the positions, or we try corticosteroid injections for pain relief, and then start the same procedure. Again, if nothing works, then other thing you can try with your patient is that try internal rotations. If my patient tells that the symptom is not better with the thoracic extension, not better with the single leg stand, not better with the scapular assistance test, or any of the maneuvers that have been resistant against external rotation, then I might go into internal rotation and then resist the internal rotation and see if that changes the symptoms. What I'm looking to see is that where is the weakness? Is there any kind of weakness going on, imbalance going on? And if that makes your symptom better, then it's more likely to be the subscapularis or anterior swing weakness or core stability. I'm going to focus more on that. If all those again doesn't help, then I might go into deltoid inhibition to reduce the painful movement. What it means is that to escape the deltoid or find a position where deltoid is not acting too much, because as you know, 45 degree to 90 degree can pull the, or it can elevate the humeral head. So finding a position at a low level, maybe around 40 to 60 degree, where I can do the cuff activity like external and internal rotation. So I might start that. That could be as simple as supporting the elbow at a pillow or a dining table or at the knee, and then doing internal external rotation, whatever range they can. Even if they can stay at the neutral 90 degree, that's fine for me. That hold is enough for me. What that tells me is that lat is pulling down, deltoid is not firing, so cuff is getting something, and if that's making the patient's pain better, that's enough for me to start the rehab. So how I progress my patient, if any of the above works, then I go for the motor control, which means the muscles which has not been working, training them, strengthening them, challenging them by increasing more repetitions, and then adding them more resistance. So first I want to get the movement correct. So if they can do correct movement without any kind of trick positions or without any kind of imbalance, showing any signs of imbalance, then I'm happy to progress in the strengthening. If they're struggling to lift their arm or if they're struggling to do the movement, I don't progress them to strengthening because I don't think they're ready. And the strengthening might, again, they recruit the wrong muscles or they might not use optimum muscles. If I'm happy with the strength or the resistance I have given them, I usually ask them to more repetitions, so low load, more repetitions, so their muscle get conditioned, and once they are ready with their endurance, more repetition they can do, then I add more resistance and progress them. So as I said, the reason why I do is that to improve the efficiency, fluidity of the movement, and also when the patient can do things by themselves, they get confidence. There'll be improved internalization of the movement and reduce errors. And most importantly, patient has learned doing right thing in a right way in the journey. Again, create physical adaptation and hypertrophy, eccentric, concentric, whatever exercises you want to add, you can progress from there. I keep it simple. I change the position, give them plyometrics, and tell them to do as much as they can do and keep challenging themselves. So keeping the goals and changing the goals to always a new one so that they know they have to achieve something. Endurance training with a moderate load, again, high repetitions, and as they get better, we progress to high load and then high repetitions. Power training we do with a high load, fast repetitions, improve speed, bridge between strength and endurance, and making sure that they're not injuring themselves, so they're getting enough activity and enough resistance. So this was a paper published by Gerber, and what they have said is that if you target motor control 10 to 13%, sorry, 10 to 30% to one repetition maximum, minimum you need to do 25 repetitions, 3 to 5 sets, having rest for a minute in between. Speed can be variable, but the frequency needs to be 10 repetitions per week. Same for the strength. So NOV means novice and ATV means advanced. So if you're looking to build the strength 60 to 70%, then obviously for the novice and advanced, it can range from 6 to 12 repetitions, 1 to 3 sets, rest in between 2 to 3 minutes, and moderate speed, but obviously their repetition is not as high. So 4 to 6 for advanced level strength training if you're looking. If you're looking to build endurance about 30 to 50%, then for novices 15 to 20 reps, advanced 25 plus reps, 3 to 6 sets. Again, speed can be variable, rest is less, and repetition per week is 4 to 8. If you want to build the power up to 32 or 60%, then obviously you want 1 to 5 repetitions. Rest is longer now, but explosive, and if you see the repetition has gone down 3 to 4 for advance. So this is how I rehab my patients. Any questions?
Thank you, ma'am. Thank you for your wonderful presentation. Madam, you covered almost all aspects from cervical spine up to the pathologies around the shoulder region. Thanks. That's very nice and very wonderful presentation. And the whole concept of shoulder rehabilitation is not only getting the head of the humerus to the center of glenoid, but also building the cognition between brain and telling the muscle to fire in the right direction. So where the shoulder rehabilitation helps us. Madam, I have questions. Now that this concept called there is the concept of proximal inadequacy leading to distal deficiency. It means the patient, say in my OPD, the patient comes with a tennis elbow. Now concept of directly looking on the tennis elbow and treating that, and I'm going to see the shoulder pathologies. Like tennis elbow, I will assess the teres minor and infraspinatus strength. So in your practice, whether you're going to do the same thing or you'll have some late protocols to do how it and how to increase the core strengthening.
Yes, tennis elbow, again, same thing. What we have learned, obviously this is not the elbow presentation, but what we have learned for any tendinopathy is that it's not a single. When we get a more load on the peripheral small muscles, which means we are not using the proximal bigger muscles. So I will go back and look at the patient's posture, looking at the thoracic extension, looking at their shoulder rotator cuff strength, and making sure that they're using the arm more and not the elbow joint more. Again, depending on the activity, what they do, but you're absolutely right, yes. Working on the proximal muscle and working on the kinetic chain, we are moving away from a single joint and single muscle rehabilitation.
Any questions, chat box?
Yes, yes.
Ma'am will discuss some questions in the chat box also.
No?
Yes,
Audible?
go on.
It's a very good presentation. You have covered almost all aspect of shoulder rehabilitation. There are some few questions. The first question is, what is the criteria you use to identify the central sensitization pain? If it is central sensitization pain, which is the best scale to be used for measuring the same?
That's a very good question. What we do is that there is a self-efficacy scale. I can give it to you. There's a pain, anxiety, and depression scale. There's a TEMPA kinesophobia scale. So these are the very good scales to differentiate between the central sensitization. But otherwise, also very quick thing you can do in the clinic is that ask the patient how long they had the pain. Where is the pain? Is the pain in the shoulder or any other joint? So if you get a multi-joint presentation, if the pain has been there for more than 3 to 6 months' time, and if you touch the patient anywhere and they say you get a hyperactive response, which means allodonia, they exaggerate their pain and tell you, then obviously these are the early signs to look into their central sensitization, which means central nervous system has got irritated or activated more. Because by touching a patient, they should not get that kind of reaction.
Thank you, ma'am. The second question, which is if subacromial pulsa impingement, subacromial pulsa is impinged during the test, what must be done immediately?
I think I have to repeat my presentation. The subacromial bursa will get impinged in anything. It's the biggest bursa. So it will get impinged in anything and every movement we do. What we don't know is that that is the cause of the pain. Because what we have learned with Karen McCree's research with Irish physio in Ireland, and she has done her PhD in that. And what she has found is that it is not when there's a reaction in the joint, there's a bursitis or any kind of reaction, it is not the bursa which swells up, it's a tendon which swells up, and the tendon which pushes against the bursa and acromion gives the pain rather than the bursa. But in this response, if it's acute bursitis or acute shoulder pain, ice is a very good analgesic. So if you've got ice cubes, don't take frozen peas or any vegetable pack. Ice cube, good ice cube in a polythene bag, wrapped with a towel, repeat it 10 to 15 minutes. That will calm down the bursa inflammation. Avoid aggravating activities. You can do gentle distractions, but pretty much the aim is to take some analgesics if the activity is affected, quality of life is affected. But ice is equally good. There are enough studies to say that ice has got analgesic effect. They can still do the isometric exercises like a paracetamol. They don't have to press too hard. They can make a strong fist, and that's enough to activate the muscle. Because what we don't want as a painful process is to get the inhibition of the rotator cuff. If the injection is the best choice, I don't know in India you can inject or not, but in UK we can inject in the ESP clinic. So I can inject my patient and send them for rehab and then get a compliance like that.
The next question, is there any case of infraspinatus wasting alone due to nerve impingement, nerve involvement, and your V1 encoding patient with infraspinatus involvement alone?
Infraspinatus?
Is there any is there any case of infraspinatus wasting alone due to nerve involvement? If so, what is your view on managing patients with infraspinatus wasting alone?
Thank you. I think that's a very interesting question and good questions. I think I haven't taken the nerve injury in depth, but yes, we know that there is a suprascapular nerve. We know that the traction, if there's a cuff tear or if there's any other pathology, the traction of the nerve can happen in the spinogenoid notch or suprascapular notch, and that can cause increased pain and weakness in the muscles. So isolated infraspinatus wasting you get when there is a full thickness tear, which means there is external rotation lag. It could be traumatic. It could be due to the nerve injury, so Parsonage Turner syndrome or any kind of long thoracic nerve palsy or any kind of cervical lesions can give you that kind of isolated wasting. I wouldn't say to be completely isolated, but yes, it's more likely to have in the cuff tears when there is no cuff and the patient is unable to move the arm. If there is any kind of fracture in the suprascapular and subscapular nerve, if there's any kind of nerve injury and this pathology. Rehabilitation will be anterior deltoid rehab program, which means we know that the patient's rotator cuff or infraspinatus or supraspinatus is not working. So what we tend to do is that we use the deltoid muscle in the supine line. So we make the patient lie down flat on the tummy and lift the bent elbow passively with the help of the other hand and take it to the ceiling. So just holding the arm in that position. As they get better, we add the weight so they can do the forward flexion. Now, as they get better, we bring them in the sitting position and then standing position if they can tolerate. But this is a long journey, and I think it's very important to know the cause and then treat that. And if the patient is not getting better, I think investigation and referring to doctor consulting.
So the next question, it is a ideal shoulder range of movement. Ideal shoulder range of movement, abduction and rotation in shoulder surgery patients.
Yes, sorry,
Hello?
what's the question?
Ideal shoulder range of movement,
Yeah.
that is abduction and rotation in shoulder surgery patients.
Which surgery?
Or
Is it
it's
rotator cuff?
mentioned clearly, or it's just mentioned as shoulder surgery. You can take any example and explain.
Okay, so if you're looking at the rotator cuff and it's a rotator cuff tear, then obviously we know that we are going to get 75% of the range of movement by the end of the 1 year. So if any patient who is going for rotator cuff tear, we tell them that they will get 75% of their range of movement what they had before. So for example, if they had 180 degree, they will get the 75% of it by 1 year. If it's a shoulder replacement patient or shoulder reverse replacement patient, then we tell them 2 to 3 years depending on the prosthesis because it can take that much time. We never tell them 100% range of movement because it's very unlikely. Sometimes it can take longer time. So it's good to give them a realistic time frame and prognosis. So I would say if it is a frozen shoulder manipulation arthroscopic relief, they will get within a week's time, depending on the stretching and exercises, full range of movement of abduction and elevation and external rotation. If it's a rotator cuff tear, if it's a partial and small tear, then they're likely to get good movement by 6 months to 9 months. But ideally, if it's a large tear, then we usually give them a good time frame of 9 months, 75% of the movement. Obviously, 100% can take more than a 1 year time. If it's a shoulder replacement, then it can take up to 2 years time to get to 75% of the movement. And if it's a reverse, depending on which processes you use, Delta or there are different kind of processes, then it can take up to 3 years at a time. And sometimes shoulder replacement patients may never get the full range of movement, and that's a realistic. So you tell them the patient, this is what you're going to get, this will be a functional range of movement. That's fine. External rotation with the replacement patient is less. So usually 10 to 15 degrees is more than enough for them to do the functional activity.
Okay. The next question is, how much extent of neck movement or pathology in neck can affect the shoulder movements?
It's very highly likely. As I said, I have been sent patients in my clinic saying that they have got bilateral carpal tunnel syndrome, but they end up having their cervical myelopathy. So they may have a shoulder pain, which means the whole body, they have generalized weakness and ache. and they have been sent for shoulder patients. They have been sent for shoulder pain, but they are not actually shoulder pain patients. So in UK, I don't know what's your setting, but in UK, we see the patients at the first point of contact, which means we have to diagnose and differential diagnose and investigate it. So it's very important because until unless you know, we all can rehab. One thing you have to understand that we all can rehab as a physiotherapist. We all can treat a patient. As a doctor or surgeon, we all can operate and do the surgery. But what is important is that diagnosis, what is causing. So knowing the cause, because if the patient pain is coming from cervical spine, there is no point you doing injecting the shoulder or doing rotator cuff rehabilitation. And same time, if the patient's pain is coming from stroke or if they had a TIA and a frozen shoulder, and plus they have cervical spine, which is causing the more problem. So when you have a 2 or 3 joint involvement, it's very, very important to understand the seriousness of a condition. So for me, cervical myelopathy is still a serious condition. I would investigate, or cervical disc or radiculopathy is still a serious condition than a cuff tear. And I will investigate that and treat that first, or at least do a pathway management that, okay, we are addressing that problem along with the shoulder problem. So I think it's very, very important. And in my clinical practice, I see most of the people over 40, majority of them are over 40, and they usually come with some kind of cervical and shoulder problem together. I never, ever get any single shoulder patient isolated.
Thank you. And the next question is the role of thoracic mobility on shoulder conditions.
Yes, it's interesting again. Thoracic mobility, we all know we are stiff in the thoracic spine as compared to other cervical and lumbar spine. Jeremy Lewis has been a great advocate in UK for thoracic spine mobility. There are published studies, but I wouldn't say that is the only cause. What you can check is that check the patient's thoracic extension and if their movements get better. So for example, if I'm elevating my arm and I get pain, but when I extend my thoracic spine, or if I move my thoracic spine differently, my pain gets better, then yes, that is the cause. Alternatively, if I mobilize the patient's thoracic spine and I feel they are stiff and the pain is likely because of that, and if that gets better with my mobilization or intervention, then yes, I do it. But otherwise, no. I'm not a very much manual therapy person. I give the patients more onus. I ask them to move their own body. I incorporate the exercises. It is important, but not too important as rotator cuff. I still feel that rotator cuff is more important when it comes to shoulder rehab.
Okay. Thank you. And the next question is, why do you think posterior mobilization is better than anterior in increasing external rotation?
Is it for frozen shoulder?
It's not mentioned clearly.
Yeah,
This
it
is
is
a straight question.
for frozen shoulder. Yeah.
Okay.
Yeah, I don't think it's not my opinion. So whatever I have given in the presentation is an evidence-based. There is a published study, and they have studies on the frozen shoulder patients. So what they think is that frozen shoulder, at the moment, our understanding is that coracohumeral ligament gets tightened, anterior capsule is tight, and rotator inferior is tight. So when you put the patient in the prone line, the strain on the coracohumeral ligament is more as compared to the position, and which makes sense to me. So that's why that may help in aiding external rotation. So there is a published study. It's not my opinion, it's an evidence-based practice. And in that published study, they have mentioned, the authors have found that evidence that posterior stretch is more beneficial than anterior stretch.
Next one is little interesting question. Can you elaborate on manual therapy? I don't know whether we can cover this question in this part.
Oh, okay,
That's
madam.
why when it comes to frozen shoulder, it's very easy. We understand whatever our understanding is at the moment. There is a muscle guarding, as well as there is some element of structural tightness. Okay, two theories are going hand in hand. What we know is that coracohumeral ligament is deep inside, so I don't think my own manual stretching might influence so much. But there might be a mechanism where I might influence the skin, fascia, and subcutaneous tissues, or some of the muscle fibers, which might give that feeling of openness, elongation, and that can help. So if the patient is prone lying and if I can do anything to open the front of the glenohumeral joint or anterior aspect of the shoulder, that's going to stretch it and open it. Because if you see what is the problem in the frozen shoulder, we are tight in the front. The anterior glenohumeral ligament is tight, which means if you wear a tight sleeve and if you put a shoulder tight shirt and hold the sleeve in front of you, you can't move. So your external rotation is limited. The moment you make the shirt sleeve release or increase the size of the shirt sleeve, you can move your arm up freely. So I think it's the same process. What we're trying to do is that releasing or opening up the anterior structure that can help. Same principle can go with the hold and relax PNF technique. I don't do, but I have colleagues who do in the clinic and they get effect. I only do what I get better with in my hands, and my hands I get better with the exercise program, injections, and strengthening exercises. So I always tell my patient to do more of swimming and active exercises, but with regards to manual therapy, there is evidence you can always mobilize them posteriorly, you can stretch them in extension, adduction, and external rotation. That will again open you up. You can do PNF techniques. You can always mobilize in any direction, and as long as you're influencing the skin and joint, I'm sure there is some active movement, and that can precipitate in increasing the muscle length or tissue length, and that can help in increasing the range of movement. Because don't forget that apart from the ligament, we also have got the skin and fascia which are tight, and sometimes it may be because we haven't moved for a long time. So there is a guarding. We all are holding because of pain. Everything is inhibited and holding like that. So some of the anesthetists or pain doctor or pain consultant, sometimes they give nerve block in the shoulder, and that can help the frozen shoulder immensely. And the mechanism again explains the guarding. So once you take the pain away, patient is not guarding and they are better. Same thing do in the theater when you manipulate. So inject the patient is asleep, and then you move their arm in internal external rotation and abduction. So the study which was done by Louis Coleman, what they have found was that there was no need of manipulation in the theater at all. Most of the patients got better by just moving the arm under anesthesia. So they are thinking it could be some form of muscle guarding. When we are awake, we are conscious of pain, we are holding us tightly, and that's not letting us move freely. But when you are asleep, so you might argue that yes, we can inject and mobilize the patient, their movement can get better. The honest answer is that manual therapy has a role, but Cochrane review has said that, and what they haven't found a good strong evidence to say that exercise therapy and manual therapy is useful in frozen shoulder. They still think that corticosteroid injection, hydrodilatation, and hyaluronic acid are much better, at least in the short term.
Then the next question is, do you think strengthening the core and lower limb muscles will have a positive impact on shoulder ADL irrespective of its pathology?
Yes, and that is again clinical experience. That is, there are no published studies, but if you know Ben Kibler, who has been advocating this, so Ben Kibler is a shoulder surgeon. He is just retired, I think, this month or last month. I had a privilege to spend time with him in US 2 weeks in his Lexington clinic, and I worked with him in his gym and theater. So yes, kinetic chain is very, very important. What we understand is that rotator cuff muscles are small, they are tiny muscles, but the amount of force required for the shoulder to do day-to-day functional activities like elevation, lifting, and things. EMG studies have shown that whenever you do a task, you're not activating just the shoulder muscle, you're engaging the entire kinetic chain starting from your calf muscle to gluteal and spinal extensor. Ben Kibler has shown in his studies or in his hypothesis that 50% energy comes from the lower limb, 30% comes from the trunk, and only 20% comes from the shoulder. So it's very, very important to address that, and it makes sense to me because if I'm a healthy person, I might not have that much of shoulder pain, but if I'm generally an unfit person, then there's no point just doing rotator cuff exercise. Yes, it may solve the problem, but the chances that if there's a deficiency in the kinetic chain, I might get the same problem again.
That's all the questions in the chat box. Thank you for your responses to the question. Very well explained. Thank you, ma'am. Over to Dr. Sharad.
Thank
Madam,
you.
what is your protocol for rehabilitation post-op cases like rotator cuff tear and shoulder replacement, even reverse replacement?
Yeah,
Just
sure.
what is your protocol for rehabilitation, post-operative
For
care?
for
Post-operative care,
rotator cuff.
rotator cuff, shoulder replacement, and reverse.
Okay. So rotator cuff repair, there's a study going on in this PD trial. What it means is that we no longer believe that we should keep a person in a sling. So if there's a rotator cuff tear, whether it's a small or large, we usually keep them in the sling for comfort, usually 1 week. We always ask the patient to take out the sling if there is a need for brushing and they're doing day-to-day activities. Um, when they are in the sling, they can do very well wrist exercises. They can do squeezing the ball or rotator cuff exercises. They can move their elbow. They can do pendulum exercises. So when I say pendulum, it's not open chain, it's closed chain, which means patient is putting the hand on a table and moving forward, sideways, and they are doing circles on the table or floor. The reason why, because what we think is that when it's open pendulum, there might be some friction going to the tendon, but when it's closed, there's a loading on the rotator cuff. So that pretty much goes to the first 4 weeks. And again, along with that, we start. So from 0 to 1 week, you do the isometric exercises, you do the active range of motion exercises, use the sling for comfort, remove it as needed for ADL. From 1 week to 4 weeks, we want this sling to be gradually weaned off, which means whenever the patient feels ready, they can take it out for the small day-to-day activities. That could be doing some cooking, doing some housework, writing, typing, or whatever. But same time, you want to increase the isometric exercises, which means pushing against the hand, against the resistance as hard they can. Doing weight bearing or closed chain exercises. So putting the hand on the table and leaning on it, or coming on the all fours, so like a cat or camel position. Your hands are on the floor and your knee, and shifting the weight through that. And as you get better, then we start doing some weight training and exercises. But it will be very much from 6 weeks onward. They can do very much functional exercises, whatever they like. We avoid heavy lifting in large rotator cuff tears, and that will be usually after 12 weeks. I think it's more because the surgeon are not confident and patient will have their own perception. I don't think it's a scientific reason. I think it's more because we have been very apprehensive with the large tears. We know that the cuff tears, even after repair, and if they tear, they're fine. Functionally, they don't have any problem, and their pain is not worse. So that way, there shouldn't be any fear. Usually, as I said, sling is for 1 week for the partial tears, medium thickness tear, but if it's a large cuff tear, you can usually have for another week extra. But otherwise, the plan is to get the isometric exercises, move the shoulder as much as possible, do the closed chain kinetic exercises, and then gradually functional rehabilitation. So rather than just taking a band or weight exercising, what the patient does in the house, what the patient does in the work. So I might give somebody like taking the any kind of pot and putting in the top shelf or middle shelf depending on how much they need it, and putting it in and out or lifting the kettle, that kind of functional task rather than taking a weight and doing exercise. Because most of the patients are busy in their life now, they have life. If I give them something functional which they can do at work and they can do at home, they are more likely to comply with the rehab as compared to just taking a dumbbell or doing a band exercises. When it comes to replacement, it depends on whether there is a cuff or no cuff, whether there was a partial cuff or no partial cuff. I'm assuming if it's a cuff, then obviously you do a shoulder replacement. And in that case, again, we work more on the subscapularis, we work more on the core, we work more on the isometric exercises because these patients have not moved their shoulder much before their replacement properly as well. So sling is for comfort only. We avoid internal external rotation for first few weeks, but again we give them isometric inner and outer range for internal external rotation from the week 1 onwards. So pretty much the same thing, but whatever they have available range, they'll be doing in that functional exercises. With the reverse, again, they don't have the cuff, so it will be more of the anterior deltoid rehab program. What it means is that we have to train their deltoid in a similar way to use the arm for the functional activities. And usually they are likely to be limited in the abduction and they're likely to be limited in the external rotation, and they have to accept that.
Thank you, ma'am. Thank you for your wonderful explanation.
Thank you so much, Jayanti, for a wonderful session. It was really, really wonderful and very informative. And I thank Dr. Sharat for being so, enthusiastic and to put his inputs and to make this session very interactive. And again, thank Dr. Padma Kumar, sir, to make this session very interactive. And I really appreciate your efforts and your skills. Thank you so much for the wonderful session. And I thank all the participants for joining us for this session. And to continue, this isn't just information as we are continuing with the series of webinars. And please do join us for the webinars by tomorrow also. We have tomorrow one more session. So please do register for the webinars. And I hope this webinars are not just the webinars, it's a good interaction what we are doing, sharing the knowledge with each other. And I'm very happy to see many orthopedicians in this webinar. Many of the orthopedicians participated here, and that was a wonderful part of us because it's the rehabilitation team what we work together. And I thank Dr. Jeevan, orthopedic surgeon, for joining us, and Dr. Imtiaz sir for joining us, and Dr. Sharath for joining us. And thank you all, and thank you, Jayanti, for the wonderful session. Have a good
Thank
day.
you very much.
Thank,
Pleasure. Thank
thank you
you.
so much. Thank you.